welcome to the very first episode of the Neuro Knowledge Podcast. My name is Scott Spielzik, and I'm a current neurology resident at the Mayo Clinic in Rochester, Minnesota. I first started thinking about creating a podcast several months ago, and really what prompted that was realizing that a number of patients as well as their families had reoccurring questions regarding a number of different neurologic diagnoses. And I think there's also quite a few misconceptions out there regarding different diagnoses and their treatment, etc. And so hopefully with the podcast, we'll be able to provide an educational resource to both patients and their families. And with that, we'll be able to dispel some misconceptions along the way. With each episode, we plan to address a particular topic and discuss that condition's symptoms, diagnosis, and treatment. Some conditions that I currently plan to address include dementia, seizures and epilepsy, stroke, tremor and Parkinson's disease, multiple sclerosis, concussion and CTE, fibromyalgia and functional disorders, amongst others. And now, just before we begin discussing today's topic, I would like to put out a little disclaimer, if you will. The podcast is not meant to be a replacement for medical evaluation, including a physical exam, and information presented in it should not be used on its own to establish a diagnosis in either oneself or a family member. An ongoing relationship with your physician or neurologist is invaluable and always should take precedent over any information you receive from the podcast. While this will hopefully prove to be a fairly valuable resource for patients and their families, it should not be the only resource. And with each episode, I do plan to include some information regarding different websites and organizations that provide excellent detailed information regarding the particular diagnoses. With that, let's get to our topic for the day, which will be dementia. I'm sure most of us have either known a family member or a relative who has been affected by dementia in some way. For myself in particular, my grandmother was pretty severely affected later in her life. It always had a bit of an impact on me. The diagnosis itself has become much more prevalent in society now that many of our family members and loved ones are going to an older and older age. Dementia is a fairly all-encompassing term to describe the decline in memory and mental abilities related to the loss of healthy brain tissue as we age. Dementia itself is not a full diagnosis by any means, and most physicians should be able to discuss a particular subtype of dementia, such as Alzheimer's or frontal temporal lobar dementia, etc. This is largely based on which area of the brain is mostly affected and the pattern of symptoms that result. Dementia is a progressive neurodegenerative condition, meaning that over time the symptoms will become more severe and become more noticeable. When thinking about mental processes as we age, I think it's helpful to think of them along a spectrum. Beginning on the left side, you have normal cognition, where there's really no deficits that are noticeable. And slightly to the right of that, or maybe halfway across the page, you have some level of impairment in memory and in cognition that would be classified as something called mild cognitive impairment. Now at this stage, this is more subtle deficits in memory, such as word finding difficulty or occasionally forgetting a person's name or where something was placed. But the deficits really don't have a major impact on your day-to-day life. A person is still able to meet all of their demands and complete their activities of daily living on their own without much difficulty. Now as we continue to move to the right across the spectrum, then the amount of deficits and the amount of difficulties with mental ability and cognition increase. We start to see more problems that creep up in day-to-day life, such as difficulty cooking a meal, difficulties handling finances, getting lost in familiar environments, even one's own neighborhood. These deficits begin to mount to the point where they're having a fairly marked impact on a person's day-to-day life. And I think this really brings us to our first misconception regarding dementia. I think there's a lot of thoughts out there that, for the most part, dementia is just a normal part of aging, that as we age, we will all develop dementia at some point. But I think it's important to point out that this isn't the case in normal aging. While there can certainly be small, memory lapses or word-finding issues, for the most part, we should be able to age and maintain our ability to take care of ourselves and to do our daily activities. And so a process such as dementia, which so severely impacts our mental abilities that we're unable to do that, is not part of the normal aging process. Now, when addressing the symptoms of dementia, I think it's important to point out that each individual is really affected differently, and each subtype of dementia will kind of carry its own major symptoms and changes that can occur. Not surprisingly, I think many people associate and are aware of memory loss in some way or another being related to dementia. In terms of the deficits in memory that become apparent, we're not simply talking about stumbling over a word or temporarily forgetting where something was placed, but rather much larger deficits in memory where perhaps recent events such as a birthday party or a major occasion or conversation are either partially or completely forgotten. People with dementia can also develop marked difficulties with their spatial orientation. Most families would identify this as someone who gets lost fairly frequently, even in environments that are quite familiar to them, such as their own neighborhood. They can walk into the wrong house or get lost driving back from a store that they visit quite frequently. I think a deficit that's more commonly asked about by healthcare providers is one's ability to complete complex tasks. These are such things such as doing taxes or ability to cook a meal, handle finances, balancing a checkbook, etc. The ability to complete these tasks is really important because they require sequencing and an individual to sort of plan ahead when trying to complete them successfully. And so when people have a lot of marked difficulty trying to do that, or those activities which they are normally able to do become fairly impaired, that is really pushing somebody towards a diagnosis of dementia and really moving over to that dementia end of the spectrum as opposed to the mild cognitive impairment area. There are a fairly wide range of additional deficits that can be seen, and largely they depend on what type of underlying dementia process is at play. Fairly commonly, people will develop speech and language difficulties, behavioral changes at times such as disinhibition or poor judgment, mood changes and apathy or a lack of drive to do things can also be fairly marked features in some people affected with dementia. Now that we've discussed some of the common symptoms that can be seen in a person affected with dementia, I think we can discuss one of the subtypes. And specifically this podcast, I'd like to focus on Alzheimer's dementia. I think most of the public is familiar with the diagnosis in one way or another. Alzheimer's disease is really a disease that begins at the microscopic level. In people affected with the condition, two different proteins build up in the brain tissue over time. The proteins are called beta amyloid and tau. The beta amyloid builds up into these beta amyloid plaques, whereas the tau forms these neurofibrillary tangles. As those two protein formations accumulate, that leads to greater and greater impact on the surrounding neurons and brain tissue. Over time, this can have a pretty marked impact on the different neural networks that are at play and that we use in our day-to-day life for cognition and problem solving and so forth. And so as the proteins accumulate over a number of years, you can begin to see more and more deficits in those symptoms that we just talked about. Also, as the proteins accumulate over time, something called brain atrophy or shrinking of the brain tissue is noticed. In Alzheimer's, the particular area that's affected is called the hippocampus or hippocampi. And really these areas are quite important for memory formation, particularly new memory formation. And so that's one of the reasons we see such marked memory impairment, especially in Alzheimer's disease. Understanding that process, you may be asking, well, what are the common risk factors for dementia and what can be done about them? The largest risk factor is actually age, and 5 to 10% of those over the age of 65 will have some sort of degree of dementia. This number increases to greater than 20% after age 85, and so really age is the largest contributor to our risk for the development of dementia. Previously we did discuss mild cognitive impairment or MCI. If a diagnosis of this is made, typically the progression to dementia is approximately 10% per year after age 65, and so once someone has developed some degree of memory impairment that has been diagnosed by a clinician, they unfortunately have a pretty high risk for eventually going on to develop dementia or a more severe form of memory impairment. The other major risk factor to identify and to become aware of is a genetic or hereditary component to the disease. There are genes that can increase an individual's risk for late onset disease, which is the ApoE4 gene. I think this is the gene that's pretty commonly tested for in home genetic testing kits such as 23andMe or others. Having this variation of the gene does not necessarily mean that somebody will develop Alzheimer's or another dementia, but it does increase that person's risk compared to someone who does not have that variation of the gene. There are other, perhaps more concerning genes which can lead to a familial or early onset dementia. However, these are fairly rare for the most part. Typically, these families will have multiple generations of people affected with dementia and affected at a pretty early age, from as young as age 30. There's been a fair amount of research looking at trying to identify different health-related risk factors such as smoking, diabetes, hypertension, or high cholesterol, and their impact on developing dementia. While some of these may have an impact, particularly in a subtype of dementia called vascular dementia, where repeated ischemic events to the brain or strokes eventually lead to cognitive impairment, their overall effect on cognitive decline otherwise and related to aging is not well understood. I think this is a good time to address the second major misconception regarding dementia, and that is the use of supplements or other substances to either prevent or reduce the risk of Alzheimer's dementia, and in some cases reverse losses that have already occurred. There are really no shortage of supplements available on the market with various aims regarding either boosting cognition or preventing or slowing cognitive decline. Some supplements certainly may have some element of health benefit, for example, fish oil. However, numerous studies have been performed on different supplements and particularly their effect on changing the course of dementia, and really those studies have never found a significant effect with any supplement that's been tested. I think the major point to keep in mind in regard to this is the progressive nature of the different dementias, meaning that they get worse over time. It's an unfortunate part of the disease, but it's quite difficult for a supplement or even medications that have been studied to really slow down this process, especially given the fact that the accumulation of proteins and the deficits are all within the brain and the central nervous system, which is very hard to get a medication into that environment. Switching gears, I think we can focus on how a diagnosis of dementia is actually made. I think a very important aspect of this is either through a primary care doctor or a neurologist having a very detailed clinical history taken and then a mental status exam performed. What this is really just a series of questions which are aimed at determining what areas of cognition are most profoundly affected. The test lasts about 5 to 10 minutes and can be used to identify any major deficits that become apparent. In this regard, there's more detailed testing of cognition that can be done with neuropsychologic testing. This is a fairly prolonged set of tests lasting anywhere from 2 to 3 hours, sometimes longer, which tests a person's mental abilities in various areas in a very in-depth way. This can pick up more subtle deficits which at times aren't really present on a mental status exam. In addition to this type of testing, there is also imaging of the brain that is obtained. Typically, either a CT scan or more commonly an MRI of the brain will be obtained, and really what is being evaluated for is the degree of atrophy or shrinking of the brain tissue, particularly in specific areas which can relate to different types of dementia. Like we talked about before, the hippocampi in Alzheimer's disease are pretty profoundly affected, and so we can look for atrophy in this region and compare it to other people of the same age. Another benefit of obtaining imaging of the brain is that it helps us to identify or perhaps rule out a reversible cause of dementia-like symptoms, such as an autoimmune process, an infection, or something along those lines. Obviously, if there's a treatable source of the symptoms and we're able to treat that, the symptoms may improve. An additional scan which is commonly obtained is something called a brain PET scan. The scan, really what it's doing is looking at the metabolism of the brain and how well different areas of the brain are functioning. The scan involves a specially labeled glucose molecule which is injected through an IV, and then when the scan is obtained, we're able to see how well different brain areas are using the glucose molecule. What this allows us to do is to see which areas of the brain are functioning well and which areas in particular are functioning not so well or less active or hypoactive. These areas in particular are the areas of concern, and there are certain patterns of hypoactivity or decreased activity that can be seen in the different types of dementia. Another investigation is a spinal tap or lumbar puncture. On this test, we can evaluate for potential infectious, inflammatory, or autoimmune conditions driving dementia-like symptoms. Additionally, blood tests are often obtained to check for potential reversible causes of dementia symptoms. What we're looking for with this is essentially certain vitamin deficiencies, infections, or electrolyte imbalances that could be contributing to symptoms, and hopefully if we are able to reverse these, the symptoms should resolve. Finally, during an office visit, a physician will likely screen for depression. The point of this is because moderate to severe depression in the elderly that is untreated can often manifest itself with dementia-like symptoms, and so we don't want to miss this particularly treatable and potentially reversible cause of these deficits. Now, if we do find a reversible cause of dementia, such as a vitamin deficiency or an electrolyte abnormality or even depression, we can obviously prescribe a treatment to help with that and correct it and hopefully have an improvement in dementia symptoms. If we're unable to find a alternative cause for the dementia-like symptoms and a diagnosis of Alzheimer's disease or another dementia is made, several medications are available to help with the dementia symptoms. However, they do not treat the underlying cause of the disease and they do not prevent progression of the disease. The medications are Aricept, or donepezil is the generic name. Another medication is Exelon, or rivastigmine is the generic name. What these medications do is they work to increase the amount of a neurotransmitter called acetylcholine in the brain. And with this increase, it is hoped that there will be a boost in cognition and hopefully some improvement in the symptoms that a person is suffering, which will allow them to be more functional in their day-to-day life. The medications are not without side effect, however, and one of the largest side effects to be aware of is their ability to cause appetite suppression. This leads to people not taking in enough to eat, but also not drinking enough, which can precipitate dehydration. Obviously, there's other side effects as well, and those should be discussed with a physician before starting to take the medication. Now, there are some people who unfortunately just don't happen to respond to the medication, and that when it is taken, there is really no improvement in symptoms that is seen. And this isn't particularly uncommon, and if it is the case, then a discussion with the prescribing physician should be had about whether the medication should be continued or not. I think an additional misconception that we can address here is the fact that these medications, or the belief rather, that these medications are treating the underlying disease, whether it be Alzheimer's or another dementia, and that isn't the case. The medications do help boost a little bit of cognition and perhaps have some benefit in that way. However, they are not treating the underlying issue, which is the buildup of those beta amyloid proteins as well as tau proteins in the brain. And so the disease will progress despite being on these medications. Hopefully with continued research, we will have a medication that will be able to target the deposition of these proteins in the brain and will lead to some beneficial treatments in either preventing progression of the disease or preventing it from developing altogether. Unfortunately, I think we're pretty far off from that at present time. Outside of medications, there's some things that can be done to help people coping with the symptoms in their day-to-day life. Many people have already started to do this by the time they're seen by a physician because some of the deficits have been pointed out by their family. So they'll be using, lists or memory aids such as a daily planner, which has all of their things that they need to do for the day. Additionally, medications may be set out in advance under the supervision of somebody else. I think one of the important things as well is to really establish a solid routine for individuals suffering from dementia. Once a routine is established, it can be quite beneficial in making sure there are no major incidents that could put them in harm's way. I believe that brings us to the end of the first episode of the podcast, and just in summary before we go, I think we can summarize what we've addressed here today. Dementia is a process which affects the mental abilities and cognition of people as we age, and it is a progressive disease. The largest risk factors for developing it are age and a genetic predisposition or hereditary factors. The underlying process at play is an abnormal buildup of proteins, which in Alzheimer's disease, which was the focus of the podcast today, those proteins are beta amyloid and tau. A diagnosis of the disease is largely based off a clinical assessment, a careful clinical assessment by a physician, as well as some testing to rule out any reversible causes of dementia-like symptoms. Treatment is available with several medications to help with boosting cognition, as well as environmental modification. The major misconceptions we addressed today were, number one, that dementia is part of normal aging when this is not the case. Number two was supplement use to treat, prevent, or reverse dementia, which unfortunately, given the major risk factors of age and genetic predisposition, supplement use has not been shown to have a major impact on modifying the rate of dementia, the progression of dementia, etc. And finally, number three, that medications such as Aricept or Exelon prevent progression of dementia when this is not the case. They do treat the underlying symptoms of dementia and will hopefully have some benefit. However, they don't prevent progression. With that, I'd like to thank you all for tuning in and hope to see you in a couple weeks when our next episode will address stroke and TIA or transient ischemic attacks. Hope to see you then. Thanks. The Neuro Knowledge Podcast is meant as an informational resource for patients and their families. It should not be used to diagnose or treat any medical condition. It is not a replacement for medical evaluation. Speakers are employees of Mayo Clinic, and views expressed are solely those of the speakers and do not necessarily reflect those of Mayo Clinic or its subsidiaries.